And so now it is on to the scientific session, which I know everybody is eagerly awaiting. And it is really my pleasure to introduce Barbara Kenner, my colleague and friend. And she is going to moderate the scientific panel. Barbara is the founder of the Kenner Family Research Fund, which is dedicated to advancing pancreatic cancer early detection. She is also a founding member of the World Pancreatic Cancer Coalition and serves on the coalition's steering committee. We get together every month to talk about the coalition. She is a member of the American Pancreas Association Foundation Board of Directors, and she also sits on PanCan's National Board of Directors and plays a pivotal role on the steering committee of PanCan's Early Detection Initiative. And so Barbara also does an amazing job facilitating this research session every year at our meeting, and thrilled to hand it over to you, Barbara, so that we can all learn what is happening in the field.
Thank you so much, Julie. And thank you for being our fearless leader on this too. So welcome, everyone. I am honored to have the opportunity to facilitate what promises to be a very informative scientific session. Our panelists are researchers who are globally well respected within the field of pancreatic cancer. They are recognized for their leadership, passion, motivation, and collaborative efforts to improve survival for patients. Full bios are included in your meeting packet. Briefly, Dr. Etna Costello. Etna, you can come on. You might need some help, Craig. While they work that out, we'll talk here. She's professor of molecular oncology at the University of Liverpool, United Kingdom. She has served on the Pancreatic Cancer UK Scientific Advisory Board between 2012 and 2019. And Dr. Costello currently leads the Cancer Research Fund UK Early Detection Initiative for pancreatic cancer. In this past year, she co-authored a paper entitled Recent Advances in Understanding Pancreatic Cancer, which I highly recommend, and we will put the link in the chat for everyone. And welcome, Etna. And Dr. Anil Rustgi, hi, Anil, is director of the Columbia University Herbert Irving Comprehensive Cancer Center in New York City. He is also a past president of the American Pancreas Association. His interdisciplinary research focuses on tumor initiation, the tumor microenvironment, and tumor metastases in the context of gastrointestinal cancers, including pancreatic cancer. His lab works to improve molecular diagnostics and find new experimental therapeutics for patients. Just as an aside, Anil this last week served as host to the Queen of Spain and Dr. Jill Biden to explain and share with them the work of Columbia Cancer Center. So we are so welcome to have you today, Anil. Over this summer, planning this session, we decided to divide it actually into three areas. The first area of discussion is prevention. This is an area we've to, but as the science has developed, the importance of strategies for prevention is apparent. The second discuss is detection, high risk factors, genetic syndromes, the value of surveillance programs, the importance of new onset of diabetes and pancreatic tests, blood and imaging, and the application of artificial intelligence to improve detection. Finally, we will look at the developments in treatment, including precision medicine, next generation sequencing, and novel therapeutic approaches, including the importance of aerobic exercise that hold promise to improve survival. I'm going to spend about 60 minutes asking our panelists questions. I've been given permission by Etna and Anil to be informal and call them by their first names. We will then take audience questions via the Q&A window. A video recording, as well as a summary sheet of the main points from this session, will subsequently be made available to all WCC members via a link. So I'm just, how are we doing getting Dr. Costello on the stage here? I see she's joining with a mobile. She was at just as an explanation for this, and I'm so happy that she's joining us today. She is in Liverpool and was at another conference, and so was back at the hotel doing this on her laptop. So hopefully we'll be able to get her in.
Yes, that's the update, Barbara, is that she is trying to join on a mobile. I'm trying to get her set up on a laptop, so it probably will take a minute or two, but you may want to just begin and continue.
Yeah, okay, we'll do. And we'll step back into some of the questions that Alpha was going to be answering. So the prevalence of cases of pancreatic cancer has essentially doubled over the past 30 years. And while the prognosis remains dismal compared to other cancers due to late stage diagnosis, significant progress has been recently made in understanding the disease and in detection and treatment. The first area that we're going to be talking about is prevention. And I'm going to skip over a couple of questions that I had for Etta and go to one for you, Anil, that we talked about the recent longitudinal study. And maybe, Craig, could you take this? We can take the screen down to the slide. That would be fine. Great. Thank you. Thanks, Anil. So recently there was this longitudinal study including 1 million Americans who were followed for 30 years, and it revealed that people who consumed 2 sugary beverages daily had a 5% increase in the risk of cancer, and 11% increase in risk for pancreatic cancer. What are your thoughts on this study results?
Yeah, well, first of all, Barbara, thanks so much for having me, and also Julie as well. I think this type of study has strengths of involving many countries and therefore many different populations. So that's good. It's hard to know precisely in a study like this, which is based upon association, if there's causation as well. So I will speculate that with carbonated beverages, especially over this period of time, that there may be artificial sweeteners, and that could lead to a hyperglycemic state or acceleration of diabetes, could also contribute to obesity. And we know that central adiposity is in particular a risk factor compared to non-central adiposity. So if you combine those two factors, hyperglycemia slash insulin resistance with obesity, then one can speculate that these factors conspire to increase the risk of cancer, and in particular certain cancers. So that's what I would surmise as a possibility for us to think about this study.
Okay, that's an interesting way to put it in the context then. Let's go back a little bit on the prevention side about modifiable and risk factors and those that are not modifiable. Can you talk a little bit about what those factors might be?
Yes, when I think about risk factors in the context of things that could be prevented, I think about it in environmental, lifestyle, and dietary. So from environmental, it would be exposure, continuous, constant exposure to air pollutants, chemical carcinogens, and that might account for the variability in the global incidence of pancreatic cancer. Perhaps it's not so much now in the United States as it might have been in past decades, but certainly in countries that don't have strict regulations with chemical disposal, air pollution, so forth, that might be contributing. So that is important in terms of government engagement and involvement from regulation. So that's environmental. From a dietary viewpoint, it would get back to a high-fat diet.
Yeah.
We know that in colon cancer that's critical. Epidemiological studies is, and we know experimentally that's critical for pancreatic cancer. So I think if one is trying to modify diet, it's particularly important to reduce the amount of fat in the diet. And in trying to make comparisons between different cancers, red meat in particular is a risk factor in colon cancer. So could that also, by virtue of the fact that high fat content is higher in red meat, could that be playing a role? And then from a lifestyle viewpoint, it would be a factor such as cigarette smoking and alcohol. Perhaps the most dramatic example is in the genetic basis of pancreatic cancer, which accounts for 10% of all pancreatic cancers. We'll elaborate in the next set of questions. There's a form called hereditary pancreatitis in which patients have acute pancreatitis very early in life, less than age 10, less than 20. And when it keeps recurring, you get chronic pancreatitis and scarring fibrosis in the pancreas. And we know that those patients who have a gene mutation that's responsible for hereditary pancreatitis, they have a very high lifetime risk of pancreatic cancer, but that lifetime risk is even more in the background of cigarette smoking and alcohol. So it sounds simplistic. In those patients, we recommend, cessation from cigarette smoking and minimal, if any, alcohol consumption. So in all these situations, especially dietary and lifestyle factors, if one has even a slight predisposition to pancreatic cancer, to a large predisposition, slight being a tendency to insulin resistance, moderate being insulin resistance plus obesity, high being genetic predisposition, then if you layer on top of that these lifestyle, dietary, and environmental risk factors, the risk goes up. So if we take that back, then prevention is critical. I think what I always find is that prevention is very hard to implement because it requires an inordinate amount of self-discipline that is continuous and longitudinal. And it's hard to prove that it's actually working because one has to demonstrate the absence of disease as opposed to one has a disease and preventing the spread of that disease.
It's interesting what you're saying because the risk factors that you're talking about, whether they're modifiable or non-modifiable, they contribute to about 40% of general cancers, all types of cancer. So not just pancreatic. So it makes detection that much more critical. And it also, from a personal point of view, with my husband, when he passed away, it seemed like everybody assumed he drank a lot. He didn't. Or that he was overweight. He wasn't. He exercised. He did all these things. So it was never being able to find why this was happening for him or what we could have done to help him prevent the development of this disease.
Yes.
So thank you for
So an extension, Barbara, of that prevention would be chemoprevention, right? Prevention requires self-discipline. And we'll talk about exercise later. So that's yet another form. So chemoprevention is, can I encapsulate all of these preventive strategies into a pill? And it's amazing that in decades of fighting cancer, let alone pancreatic cancer, we have not made the same type of dramatic advances in chemoprevention like we have in therapy. And I think that speaks to many, many complex issues, and that chemoprevention is under-resourced in research and under-pursued in various domains. So that being said, a simple chemoprevention in reducing the risk of colon cancer after surgery is a baby aspirin. If one has colonic polyps, baby aspirin, both are effective. So, we don't know if the combination of various things that are both prescription and non-prescription might be helpful in chemoprevention for pancreatic cancer in the right setting.
Yeah, but hard to know who's to take the chemo, right?
Yeah.
That's the other problem with that too. So I'm just reading some Etna's notes to me since she's still having a difficult time getting on. And she talked about risk reduction strategies, including regular exercising, having the risk of pancreatic cancer, maintaining obviously an optimum weight, giving up smoking will lower the risk, as well as avoiding heavy alcohol consumption. She also wrote an interesting article that discussed pancreatic cancer prevention. And I would encourage everyone to read this, because it does look at some of the uncomfortable truths in anyone who might get pancreatic cancer, as well as, again, looking more in depth in some of the risk factors involved with it too. Pancreatic cancer, like many cancers, doesn't affect all populations equally. Can you talk about diversity, the importance of diversity, and including gender, race, ethnicity, age, geographic area, and how it may impact research, how it impacts prevention, detection, and treatment?
Yeah, I'll try to go through each of those factors. Gender, male greater than female, but that there may be no biological underpinning or basis for that, but that might reflect disparities amongst men greater than women in proclivities for cigarette smoking, alcohol, and obesity and insulin resistance. So that could be a surrogate, if you will, of all these other factors. In terms of age, it is largely for sporadic pancreatic cancer, which constitutes, let's say, 85 to 90% of all pancreatic cancers. Largely, not exclusively, but largely a function of age. So the median age is 67, but we're with longevity. We are seeing patients present with pancreatic cancer in my own practice in their 80s and 90s. And I think that probably is a reflection of, of, of changes in cells and tissues, because the risk of all cancers goes up with aging, and especially now with greater longevity in the United States and developed countries. So those are the two big things to think about.
And we also know that
and race, I'm sorry,
Black
race,
community
yeah.
also has a larger incident rate, much higher incident rate too. And they often present at younger ages with more advanced disease.
Yeah.
And so when you talk about having patients in their 80s and 90s, there's also another question I was going to ask you, which had to do with the patients that are now being diagnosed much earlier, like in their 40s. Yeah. And I haven't seen any statistics on that to really know if this is if it's a trend that we are going to be seeing in the future. But that really has a lot of implication for those of us who have children, right, and at what age that they should start surveillance and be in some type of program.
Yeah, I'll reinforce the point about race and ethnicity, that pancreatic cancer spares no particular group, and the outcomes may be worse in certain ethnic groups, certain races. Now, again, is there a biological basis for that, or is it that the factors that predispose to sporadic pancreatic cancer are more prevalent in such races, especially from the viewpoint of diet and obesity and insulin resistance? Mm-hmm. I think that this is being observed in a number of cancers. It's not restricted to pancreatic cancer, that there's earlier and earlier onset. And number 1, 2, and 3, one has to make sure that in early onset pancreatic cancer, that there's no genetic basis for it, that it's not hereditary. So germline genetic testing is absolutely imperative. In fact, the NCCN recommends germline genetic testing, in everybody with pancreatic cancer at this point, so universal screening, if you will. When one sees a dramatic increase in a given cancer, let's say in our case, pancreatic cancer, in a certain age group, younger age group, in a compressed period of time, that does not speak to genetics, but it speaks to non-genetic. There's something in the environment that is occurring, and superimposed dietary lifestyle factors. One possibility, because this is the subject of much debate in early onset colon cancer before the age of 40, would be, is there a change in the gut microbiome? So a tension between good bacteria versus bad bacteria, use over abundant utilization of antibiotics. So that changes the gut microbiome. Diet changes the gut microbiome. So we call this dysbiosis. And certainly that's been linked to colon cancer. And there is some literature suggesting that dysbiosis might play a role in pancreatic cancer, certainly in experimental models. So if that is the case, that there are dramatic changes in the microbiome that then catalyze changes in the pancreatic tissue from normal to pre-cancer to cancer, that could be one possibility. Very hard to prove epidemiologically because you really need to study then cohorts of patients over decades to be trying to make these types of conclusions.
And so what would that mean functionally for prevention, for instance, or detection?
Well, it could mean certain types of antibiotics. It could mean probiotics. I'm very careful to state these things because I wouldn't want people to take the message away. Well, let me start taking a probiotic off the shelf or some supplement in the absence of data, and those, it can be a financial burden for some people as well. But that's what it might translate into.
Okay, interesting.
One other aspect is that in individuals with inflammatory bowel disease or ulcerative colitis, exchanging good bacteria to replace the bad bacteria, apart from antibiotics, is in fecal microbiota transplantation. So injecting a donor fecal content, and that's been shown to ameliorate ulcerative colitis. So you could imagine that for the upper GI tract as well.
Great, thank you. So just one other in this area, or actually a couple things quickly. One is surveillance for high-risk individuals, and those are obviously coming from families that have genetic dispositions, or someone within the family, a blood relative who has had pancreatic cancer with a mutation. What does a surveillance program involve? What does it look like? And if you could talk a little bit about Mike Goggins' recent study on this, and then even Brian Wolpin's study on type B blood type, because that sort of comes in with this as well.
Yeah. So the Wolpin study suggests that there's an increased risk of people with blood group type B, right?
Yeah.
And I think in that context, it's probably a surrogate for something else, whatever something else is. And so it's been well known for decades that those individuals with blood group type A are at increased risk for gastric cancer, in part or to a large extent because patients with blood group type A are more susceptible to Helicobacter pylori infection, so which is a big risk factor for stomach cancer. So I think it's a surrogate, or it leads to something else, sort of a chain of events. In terms of surveillance strategies, it's largely born out of those patients who have genetic predisposition. And so you family history, that's my own practice. In fact, prior to coming on this conference, lots of patients who have got, as explained, get genetic test results, or they're about to get genetic testing. So based on the robustness of the family history, as well as and or a gene mutation, then there's enough evidence to suggest that there's efficacy in surveillance of the pancreas. The manner in which it's done, we favor endoscopic ultrasound based upon our studies, but it should be either endoscopic ultrasound or MRI, MRCP done on an annual basis, starting at age 50, or if it's early onset pancreatic cancer, 10 years younger than the index patient or proband. So that's that with genetic predisposition. But we know, or it's estimated 20 to 30% of sporadic pancreatic cancer have type 3C diabetes mellitus. So that's to be distinguished from type 1 or type 2. Type 1 being insulin dependent, type 2 adult onset, may or may not be insulin dependent. Type 3C is relatively recent onset diabetes within like 18 to 24 months of the diagnosis of pancreatic cancer. And so there's a notion that screening for glucose and hemoglobin A1C may be helpful. Now, how do you do that in the general population? It's impossible. Although in primary care medicine, more and more screening generally for diabetes is being done for hemoglobin A1C.
Yeah, and this is really
it's a fascinating area. It really is.
And it's Ethna's area of expertise and what she's been doing in her studies in Europe on nuance of diabetes. But hopefully she can be on for that portion and talk a little bit more in depth on it. One last question here under prevention is, what role do public health interventions play in primary prevention at a population level?
I'm sorry, could you restate that question?
Sure. How do public health interventions play in primary prevention at a population level? How do they impact that?
You mean general guidelines or general recommendations?
Yeah. Mm-hmm.
Yeah, I think in part this is through this, at least in the United States, through the Center for Disease Control. Just like the CDC recommends universal screening for hypercholesterolemia, Lynch syndrome. And so the CDC can be extremely helpful, reinforced by other federal agencies. The second is that professional societies play a huge role in having task forces which sort of percolate up to the U.S. Preventive Health task force that comes out with recommendations on a regular basis about screening and surveillance. So professional societies are extremely helpful as well. I'd say those two are big pockets. And then at an international level, the World Health Organization is extremely helpful. And obviously, organizations like the World Pancreatic Cancer Coalition are extremely helpful too.
Yeah, it seems like from what you're saying that they play not only a role in detection, which we've been very focused on, but also in prevention. The information that you provided today.
Education and awareness are absolutely critical. That is the biggest opportunity and also the biggest barrier at the same time.
Thank you for that. We're going to move on to detection now. And we just may be here together today until just the two of us. And
I'll probably run out of my knowledge base very soon. So.
No, I don't think so. We'll just, you know, Esna also had a lot of information about what was happening in the global area. So that was so terrific too. But many of us consider earlier detection of pancreatic cancer as a pathway to improve survival. And it's really a highly researched area. I don't know, I read the statistic once that there was like 2,000 papers written on biomarkers for early detection, and not one of them was successful. But we do know that there has been progress in this area, but there is still no single detection protocol for the population, which indicates that early detection remains somewhat elusive, improved, but still elusive. So I know that you have a lot of background in the genomics that characterize early pancreatic cancer, but if you could sort of focus that on how fast does this disease grow? What is the window for the patterns of detection that make a difference? And then to round that out, what are the benefits and harms of finding pancreatic cancer early?
Okay, in any disease, let alone pancreatic cancer, want to detect it early. There's absolutely no doubt. So one is try to detect it at a pre-malignant to pre-cancer stage, because then some intervention can be done to eliminate progression. The second is if disease is found at an early stage, typically either endoscopic or more commonly surgical resection uh, uh, is or might be curative. So that's the rationale for early detection. Catch it at a precancer stage or early stage cancer, because some of the best interventions still are endoscopic or surgical. Now, how do we go about early detection? And I think, stepping back, I think of it as cells and tissues are secreting DNA, RNA, protein, uh, or cells themselves are being secreted. So where are those cells being secreted into? Blood, but also other bodily fluids. Saliva is used to for oral cancer, sputum for lung cancer, urine for bladder cancer, stool for colon cancer, but there were studies a long time ago detecting pancreatic cancer based upon stool or genomic changes or genetic changes in the stool. Um, so think about bodily fluids. So then in that bodily fluid, one can find um, cell-free DNA, RNA, or protein. One can find cells as well. And then the cells, one can see, are they normal or cancerous? And then one can also analyze the DNA, RNA, and protein in those cells. So those are sort of the um, tests, so to speak. Secondly, it's awfully hard to, in early detection, to rely upon one abnormality. And so I always urge people to think about more realistically, it's going to be a panel of abnormalities, whatever those are, in an effort to improve both sensitivity and specificity. You'd like to get to at least 70% sensitivity and over 95, 98% specificity in a panel of tests, whatever that is.
Yeah.
Then another area is, well, how am I going to detect all these things? And so the platforms are just exploding. And they're largely molecularly based. And ideally, you'd like to be in blood for the ease of obtaining sample, analyzing sample, and frankly, for the ease for the patient, right? A lot easier to get blood taken. It's easy to submit saliva and sputum, but not so easy with other bodily fluids, right? So then there are from experimental approaches to commercial application where blood is used as the framework for trying to detect um, these genetic abnormalities, um, and then um, uh, and then you match it up with, am I detecting these lesions early with standard measures such as imaging, either non-invasive or invasive. So that's how I try to think of it, as sort of in a stepwise way, and that we be very careful that we just don't jump on the latest test, because I've been around long enough in my training in the 80s and 90s when it was almost the same type of intense attention on the latest biomarker, and we'd all jump on the bandwagon. And so we have to be very careful, just like with therapeutics, to analyze the diagnostics with the same type of rigor.
Okay. And so functionally, by having more than one approach, it seems like the general practitioner, given that information, would have uh, increased ability probably to send somebody out for a scan, at least at that point, if something in one of those didn't come out correctly.
Right. So if you detect something abnormal, what's the next step? Yeah.
Yeah.
You
Yeah.
may want to do additional blood tests, right?
Yeah.
Imaging is probably going to be the way as the next step, assuming that your panel of tests are pointing to the pancreas.
Yeah. And so when you talk about imaging, there's been a lot of work on artificial intelligence in that area.
Yeah.
And how does that improve the imaging for pancreatic cancer?
It's more after the diagnosis has been made. So in the context of the pancreas, like chronic pancreatitis or pancreatic masses, pancreatic cysts, using tools of machine learning to study hundreds and thousands of images and coming up with algorithms that allow you to predict the outcome of an abnormality to something that might progress. In terms of that's more when things are have moved along. But in terms of artificial intelligence and machine learning for early detection, that's not as far along as once the diagnosis is made.
Okay.
But I think that's only going to improve over time. We're seeing that in different tissues and organs. Yeah.
Yeah, yeah, okay. I'm going to dive into a little bit of Ethna's work here so that we can cover it. I know I got Craig still, they're still trying to diagnose the issue with her laptop. So much of her research has been based on the relationship between new onset of diabetes. Some call it type 2 diabetes new onset, some call it what you were to, Anil, type 3. And what she was talking about, she said when diagnosed with pancreatic cancer, the majority of patients, like almost 80%, are not regulating the blood sugars correctly. They either have abnormal fasting glucose or glucose intolerance or full-blown diabetes. And can you just talk about how this new onset diabetes could be considered an early warning sign and in pancreatic cancer? And you typically it's 24 to 36 months before the pancreatic cancer diagnosis.
Certainly, studies of cohorts of patients, population-based studies, suggest an association with this a unique type of diabetes with pancreatic cancer.
Yeah.
Okay. I think there's not much debate about the veracity or authenticity of that association. Then, like, what's going on? And that's somewhat unclear. You'd like to be able to do test hypotheses and experimental models. I think of it as that there's something about insulin signaling that's causing normal cells in the pancreas to become abnormal. And we know for a long time that insulin signaling will induce the activity of growth promoting genes that are also cancer related genes, things like what's called AKT. So if that's going on, you can imagine how the constant activity of insulin mediated signaling is fooling the cell into thinking that it should come out of a homeostatic normal state and just keep continuously proliferating. And then that abnormal proliferation might lead to all of a sudden some cells have a KRAS mutation. And then, you get a spiral downwards. That's what I think is going on. But that's speculation on my part, but we don't know with precision what is going on with that diabetes, recent onset diabetes and pancreatic cancer. But I actually think it's fascinating, not just from a pathophysiology viewpoint, but boy, if there's one intervention to do in the general population, that's it. It's right there. But then how do you apply that to the general population?
Yeah, and my understanding too from her work was that it wasn't people who had long-term diabetes, although there was a slightly above higher incident rate, but with this type, with new onset within those 2 to 3 years before the diagnosis, is that they had a 6 to 8 fold higher probability than the general population of developing pancreatic cancer, which is huge.
It's enormous. That's a lot of people, right? So
Yeah,
I think we do a really good job with family history, genetic testing, screening, surveillance, prophylactic measures, right? I think there's a huge spotlight on that. I think we need to get that same equivalent intensity or spotlight on the recent onset diabetes. And we all have to be thinking about the possibility of pancreatic abnormality, bringing those patients in much more frequently, and maybe
monitoring.
reducing our threshold for pancreatic imaging. You
Yeah.
know,
Yeah, and my the other bit of information that was really fascinating to me is that it is the tumor that's causing the diabetes versus the diabetes being the cause.
could be going
Okay,
on as well,
right. So
which,
then if you have surgery and you remove the tumor, the diabetes goes away.
yeah.
Is that correct?
So I think you're totally right, Barbara, that it's likely bidirectional, that
Yeah.
it's contributing to tumor formation and the tumor formation is contributing to the diabetes. Yeah.
Yeah. Can you talk a little bit more about some of the other biomarkers that are currently being developed that you find interesting? There was an Esna again had was covering the saliva samples that were from the Spanish PDAC patients, and also looking at the Japanese set of samples that had to do with gut and oral species. And how are these? They're all in sort of what I call bench science versus ready for prime time. But where do you see the promise in these various areas? And again, I would say to you, how wonderful that globally people are working on this
Yeah.
in different areas. And are they collaborating as they're doing this? That's my
Yeah.
other question too. And I think the whole coalition wants to know the answer to that.
I would like to give a shout out to the global efforts and the great science and medicine ongoing in many, many countries across the world. Collaborations are imperative. Collaborations are occurring either at an individual level or an institutional level, um, uh, and they're often facilitated by professional societies and other types of organizations. So the roles that societies and organizations play are absolutely critical. There's no dearth of biomarkers. Um, some of these, again, getting back to an earlier point, are DNA based or RNA based or protein based.
Mhm.
You'd like it to be protein based because then you can develop antibodies if they don't exist already, and then you can measure that through something called ELISA or Western blot. Easy to do, uh, can be done on a daily basis in standard labs. So, and then non-cellular would be more bacterial. Um, could there be a signature of bacteria that represents a biomarker, or could there be something made by the bacteria, metabolites that then injure the pancreatic tissue? So I don't have a magic wand to say, it's markers A, B, or C, but um, you know, regardless of the marker or markers, they have to be subjected to rigorous testing. You like to do it in a cohort of patients, call it your training set.
Yeah.
You'd like to validate that in another group, totally independent group. Then you'd like to scale it up to the general population. Well, that takes a lot of time, effort, and frankly, funding too. It's I think sometimes people don't realize that diagnostic testing has to go through the same type of rigorous review as the development as therapeutics do in the FDA. And because it takes time and money, and the return is not as fast as it is on therapy, that's why I think in part the attention to biomarkers hasn't been as great in pancreatic cancer or other cancers as it has been with therapy.
So if we go back to what you talked about with surveillance better for a moment in prevention, so let's think about high-risk family members of someone who has had pancreatic cancer. What role would biomarkers play in that surveillance? And what does surveillance look like globally? We know even in this country that it varies by whether
Yeah.
you're diagnosed and treated in a community center or whether you're at Columbia University. Those are two very different types of centers. Can you just address that for a moment?
So if I think if I understand you correctly, it would get back to at-risk individuals in the family
Yeah.
of someone.
Mhm.
So there, um, the availability and accessibility to resources does vary, whether it's within the United States, let alone across the world, because the pancreatic imaging is suboptimal with ultrasound, which could be done across the world. Then you have to get into either, marginally invasive endoscopic ultrasound or cross-sectional imaging with MRI, MRCP. So then application of that across the world is challenging. Uh, One, because how do you deliver that
Yeah.
across the world? And two, these things cost money. So I think your point, Barbara, is correct. You have to keep getting back to biomarkers because, whether it's blood-based or something like that, because that's going to be much, much easier, quote unquote, easier to implement across the world in the United States.
Yeah, and without it being invasive, also,
Yeah.
from what you're talking about. Yeah, okay.
And,
Um,
and then if you're using endoscopic ultrasound or MRI, then you have to have the expertise to not only do the testing, but interpret it. Whereas if it's biomarkers, it tends to be a little bit more binary, up, down, and if it's up, how much is it up? So interpretation's a lot easier too.
Yeah, you remind me of a conversation I had this last week with a wonderful general practitioner in Wisconsin in a small community center. And he was talking about this and saying, what do I do? How do I do surveillance? Give me some information. So people are, he is someone who really wanted to do this, to incorporate it into his practice, but was unsure of how to go forward and actually do it.
The 1970s and 80s witnessed bio, the integration of biomarkers that still are present. So one could say, well, those are good biomarkers. One could also say we're not making much progress. So these are all proteins expressed on the cell surface. They're very big proteins. They're what are called glycoproteins, and so they're CA19-9,
Mhm.
CEA, CA125, big top three. You would think after 35, 40 years we'd be further along than that, but I'm just speaking about clinical practice now, not clinical trials that are looking at biomarkers. We're still utilizing those. So in my practice for pancreatic cancer, test for CA19-9, which can be helpful after therapy if it goes down, and it might go up with recurrence, but it shows you the stubbornness of the biomarker field that we're still using those things that are decades old.
So last year during the scientific session, we discussed some of what I call out of the box ideas for detection. And one idea in particular was monitoring human waste on a personal or population level. Somehow this doesn't seem as extreme this year as a technique, given that it's being used to monitor COVID-19 and now polio in communities. Could this approach have use in diagnosing cancer and specifically pancreatic cancer?
Yeah. So one could think about it as what is present in human waste or human feces. Um, One would be bacteria. Okay, so the ability to sequence the bacteria is quite fast, just like human genomics, bacterial genomics, you can sequence and interpret. The second is cells that are being shed by human tissue, and you look for mutations. And the third would be there are metabolites made by the bacteria that might be good or bad. Oh boy, I think it's going to be hard. Again, getting back to collection, storage, processing, and then the analytics, all that takes time and it's expensive at this stage. So the idea might make intellectual sense, but the practicality of it, I think, is quite daunting at this point in time.
Yeah. Okay. Thank you. So we're going to move on into the treatment area right now, and treating pancreatic cancer successfully has improved, but it certainly remains challenging. And if you, Anil, could give us in preparation for this session a little what the approach is for standard of care in pancreatic cancer. And then so we have that as a context for the background of some of the other areas we're going to talk about.
Okay. A lot of credit to Julie and PanCan for driving the country and the world to improvements in survival rates. So that's really important to emphasize. Okay, it's like with any other cancer, it's stage dependent. So this gets into early detection. So if you can detect something at stage 1, which unfortunately accounts for a small minority of all pancreatic cancers, you can do surgery. And the morbidity associated with surgery now is quite low because of the expertise of the surgeons and the surgeons team. And 5-year survivals are, 20%, 25, 30%. Okay, so that's the best scenario for subsets. So that's called localized disease. If there's locally advanced disease, in the past it would be chemotherapy, and that would be it. Sometimes chemotherapy and radiation therapy, but now in this, there's a desire to shrink the tumor with chemotherapy to hopefully make the patient eligible for surgery. So neoadjuvant chemotherapy followed by surgery, not always, but in well documented cases of locally advanced disease. Then you get into metastatic disease, and the most common sites for metastatic pancreatic cancer are liver, lung, the abdominal peritoneal cavity, and the bone marrow. If you look in the bone marrow, often you can find evidence of cells. There, surgery does not make sense unless there's obstruction from the pancreatic cancer in the duodenum that might require surgery or endoscopic placement of stents to improve passage of food. And there, FDA approved are 2 different regimens, both of which improve median survival and overall survival. So typically, unfortunately, when our patients present with metastatic disease, apart from germline genetic testing, then they'll get standard of care chemotherapy. If the standard of care chemotherapy fails, or the patient wishes to bypass the standard of care chemotherapy, then clinical trials are really critical. And as Julie and Pancas articulated, the goal is to have every patient, if at all possible, enroll in the clinical trial. That's how we're going to learn more, not only about pancreatic cancer, but in a customized or personalized way.
Mm-hmm.
So there's no dearth, there's no shortage of clinical trials. It's really important to be aware of them through PanCan and other organizations, as well as one's local center, and multidisciplinary teams are really, really critical.
Yeah.
The question often comes up about immunotherapy. So
Yes, what?
pancreatic
I'm sorry.
immunotherapy.
Immunotherapy.
Yeah. So it is pancreatic cancer is often referred to as a cold cancer because of uh, the dense stromal response, scar-like tissue, desmoplasia. You know, when you look under the microscope, there's hardly any tumor cells. It's mostly fibrotic tissue. You see that in liver cancer also. Then a couple of things happen that um, that desmoplasia compresses the blood vessels, so drugs can't get in. The drugs may be good, but they're not getting to the tumor cells. Or it could be that the desmoplasia is pro-tumorigenic, and it doesn't matter what drugs you give. So as a result, good immune cells, called T cells, are excluded from the tumor microenvironment. But unfortunately, bad immune cells are able to get in that are immunosuppressive. So if you can somehow improve T cells getting in, they'll kill the tumor cells, but it's daunting. And so currently, immune checkpoint blockade with PD-1, PD-L1, it's only good for about 1% of all pancreatic cancers. So unlike melanoma, kidney cancer, lung cancer, where immunotherapy is really doing great, that's not the case with pancreatic cancer.
So is that, I was just at the AACR last week, and there was a talk on chemo in immunotherapy combination. Is that still so resistant?
Chemo plus immuno?
Yeah.
Yeah, that's typically still done in clinical trials. Yeah,
Okay.
but
Okay.
I think we've got to take a fresh look at immunotherapy and think of different targets, frankly.
Mm-hmm. Okay. Esna had, and thank you, Esna. I see she's on here somewhere, but just can't get in. She had written, in general, I think it's worth saying that the improvement of overall outcome that I've seen in the 23 years working in pancreatic cancer is encouraging. When she started, overall survival was 3%, and now, of course, it's nearly 11%. Still a long ways to go compared to other cancers, but that is a significant completion there. She also talked about neoadjuvant therapy treatment, and this is one that's being done in Korea in a multi-institutional trial. And they found that patients given neoadjuvant chemo and radiation had better 2-year survival than those in the upfront group. The other that she wanted to talk about too today had to do with the PARP inhibitors in individuals with germline BRCA mutations. And so for the 5 to 7% of patients with the BRCA pathogenic germline variant and metastatic PDAC, a polydiphosphate, I really wrecked that, inhibitor is a maintenance option that improves progression-free survival following initial platinum-based therapy. So it seems like there's something beyond just the platinum-based therapy to help individuals with that. I think everybody here would be really interested in hearing about precision medicine, what it is exactly, what does it mean for pancreatic cancer, because it's a term we read in the paper on a lot of things.
It might be overused too.
So you can talk a little bit about that. That would be great.
So just to dwell on your point that if you look at the gene mutations independent of RAS and P53, BRCA1, BRCA2, PALB2, ATM, they all are involved in repairing DNA damage. That's a recurring theme. And so that's where the opportunities for PARP inhibition comes in, much like we've seen in breast cancer and ovarian cancer.
Mm-hmm.
So I think there are, and one of the reasons that cisplatin works is even if one doesn't have the information about BRCA mutation, one might operate under the premise, well, there might be a BRCA mutation. Let me come in with cisplatin-based chemotherapy because it will help there. So when we see good responses with cisplatin-based chemotherapy, it's likely because there's a BRCA mutation. and then you can enroll them for further studies with PARP inhibitors.
Yeah, and into clinical
So
trials, obviously.
I think with personalized medicine, personalized cancer medicine, so we're not going to be talking about germline because that's a different type of personalized medicine. It's very focused on panels. The idea would be to look at the the mutational profile in the tumor itself to see if one can do some matching of a particular mutation with a targeted therapy for that particular patient. So
I want you to clarify something because this is a point that comes up a lot. So a genetic variant, like a BRCA, et cetera, an ATM in pancreatic cancer, which are most common, is different than what you're talking about now, which is a variant in the actual tumor.
yes, yeah.
Okay.
So again, I think of personalized as at the germline level, so BRCA, ATM, PALB2, etc., but also at the somatic level is the term that's used in the tumor itself.
Yeah.
So it's very interesting. The notion had been in the 2000s and early 2000 teens that after RAS mutation, which is found in 100% of pancreatic cancers, and P53 and P16 mutations, which are 60, 70, 80%, that there would be discovery of a whole landscape of other mutations. Actually, not the case. So the fundamental principle, overarching principle, is match the tumor behavior with therapy off the shelf. But then you got to make sure that you can quickly implement that in that patient. You may need to get approval from a company to use the drug. You may need to, depending on the drug, it may require an IND to the FDA. But in pancreatic cancer, the tumors don't have this huge panel of different, of a lot of genes that are mutated. It's quite restrictive. And the genes that are mutated, it's hard to match up personalized therapy. However, except for one, there's RAS mutation, RAS, and the mutations in codon 12, so it's called G12C. There's a lot going on there in drug development to suggest that that might be helpful. So a lot going on in lung cancer, and we're going to see if that might be helpful in pancreatic cancer. So does that make sense? Precision medicine is analyze that tumor, and that's doable. And is there something beyond standard of care that can be customized to the patient? A little bit more daunting in pancreas cancer.
And the other point of that, Anil, is what is the quality of life too? The quality of life.
Yeah.
So the treatment may be there, but is it so rigorous that it's difficult? Does it compromise the quality of life? Is that something that's taken into consideration quite often?
Absolutely.
Great.
Look, all of you in the audience are, and we all are dedicated to our patients first and foremost, their families, their caregivers. We also think all the time about the communities in which they reside, their faith organizations, their schools, other entities. So one has to take a very broad view. It's a very holistic view, not only about the patient, but what's the impact on the family, the caregivers, the economic impact, the social impact, the educational impact. So we dedicate a lot of resources to these efforts because yes, early detection and therapy are absolutely critical to make inroads, but they can't be done in a vacuum in the absence of taking into account all those other factors.
Yeah. Vaccines. This is a whole area that's developing, and some utilizing the mRNA technology, which I guess we all know what that is now at this point.
Yeah.
Can you talk a little bit about how that vaccine is actually proposed to be used? Is it used prior to surgery, after surgery, or
Yeah.
when exactly does it come in place?
Yeah, I'm not the most expert on this topic, but conceptually speaking, the vaccines would likely be after surgery, and one would develop vaccines against certain tumor-associated antigens, okay, that occur frequently in pancreatic cancer. So you do the surgery, but there's likely still microscopic disease left that you just can't detect by imaging, right?
Yeah.
So patient feels well. You can't detect any disease, but it's smoldering. And the experimental models indicate it's smoldering. So the idea would be, well, let me come in with a vaccine against antigens expressed on the tumor cell surface to kill residual tumor cells. That's the whole premise of vaccines.
And these are in clinical trials at this point, is my understanding.
Yeah, it's a very difficult strategy
Hmm.
for cancers, not for infectious diseases.
That's a better use there. But the vaccine approach in general, would this eventually or potentially have also some use in prevention?
Yeah,
I'm going
that's
off. I'm
perfect.
off. Okay.
To the audience,
Only
Barbara
that.
knows much more than I do. So, but I think that's perfect. If one could come up with preventive strategies through vaccines for people predisposed,
Yeah.
you wouldn't want to be giving it to the average risk general population.
Right.
I'll give you an example where it might be applicable, and that's Lynch syndrome, the most common type of hereditary colon cancer. Now, some of those patients are at increased risk for pancreatic cancer, but um, the immune system is awry in Lynch syndrome, and the idea would be to develop vaccines to tumor antigens or tumor peptides, and then give that to the patient, once a year, twice a year, whatever. And because they have an 80% lifetime risk of colon cancer. Now we deal with it through colonoscopy every year and eventually removing the colon, but those are huge interventions. So that would be, I think you're totally right, Barbara. That would be the idea, could it be a preventive strategy?
Okay.
And you might not need to give it as intensely as immunotherapy, which is like every 3 weeks. Maybe you can get away once a year or twice a year.
Thank you. Um, there was a recent article entitled "Get Up and Sweat to Treat Cancer." It indicated that aerobic exercise reprograms the immune system to reduce PDAC tumor growth and increases the effectiveness of chemotherapy. Now, this research is from the article was involved mouse studies, um, and it was commenting on this that it had to do with a type of T cell that was impacting this and helping it, so that it did actually slow the growth of the pancreatic tumors and induce cell death. And this is a long way, obviously, from validation, but it's an interesting area because it's something that everyone could do without having to. You need a trainer more than you need, your oncologist on this. Do you have any thoughts on this?
Well, I think exercise is helping um, cardiac function, obviously, but it's reducing the deleterious effects of fat cells or adipocytes. Because in obesity, these adipocytes are secreting pro-inflammatory, pro-tumorigenic cytokines, interleukin 6, interleukin 8 in particular, and those then hone in on a particular tissue and convert it from normal to abnormal. So I think exercise is a key vehicle for reducing weight, and reducing the circulation of pro-inflammatory, pro-tumorigenic factors.
Okay, so that sounds
At
good.
our cancer center at Columbia University, we have a pretty extensive program for exercise therapy for our patients.
Okay.
First of all, the patients love it. But from a scientific viewpoint, we think that's what's going on. And it likely then, as you indicate, it's helping with the immune system as well.
So we'll look forward to hearing about the results from that study when it's completed. It'll be interesting for everyone to read. Pancreatic enzyme replacement therapy, commonly known as PERT, shows to have the potential to improve symptoms, nutrition, weight loss, and survival. However, there seems to be a general lack of awareness about the use of PERT in pancreatic cancer. What is this reason?
Yeah, just for everyone's edification, the pancreas, again, has two compartments: endocrine, so islet cells that are making hormones, especially insulin. If you look under the microscope, they're islands. And it's 100 years now from the Nobel Prize for this. And then the exocrine compartment, which is, most of the pancreatic tissue mass, that has acinar cells, the stalwart of the pancreatic tissue, which make enzymes, digestive enzymes, that go into channels or ducts that empty out into the duodenum so digestion can occur.
Mm-hmm.
Okay. So the endocrine compartment, that's when that gets damaged, it's autoimmune in type 1, life-acquired risk factors for type 2 and type 3 we've talked about. When there's damage to the acinar cells, typically by alcohol, but certain other factors as well, and repetitive damage, that's what's called chronic pancreatitis. And we're not making enough enzymes, and not enough enzymes are getting into the duodenal lumen, so not able to have as much digestion of fat and carbohydrate, and that's why that's called exocrine insufficiency, and we experience diarrhea, fat in the stool called steatorrhea, and weight loss. And you can look for elastase in the stool as a marker of that. So because we're not making enough enzymes, one way to get at that is exogenous enzymes, coordinated with meals, and that helps then digestion and mitigate against maldigestion. Well, because of the burden of the tumor in pancreatic cancer, it's sort of squashing acinar cells. So not enough enzymes are either being synthesized or secreted. So it's the same principle. Well, if we're not making enough enzymes or releasing enough enzymes, we want to give it exogenously. And I think really with careful history, a fair number of our patients with pancreatic cancer would benefit from enzymatic supplementation or replacement. And that helps improve quality of life too, by maintaining weight or restoring weight. People are more active, able to exercise, and also it helps improve response to standard of care chemotherapy and helps enroll in clinical trials. So it sounds, I think why it's not emphasized enough is one, lack of awareness amongst providers. And secondly, it sounds so simplistic that it makes no sense. It's too simple. And it's not meant to be a panacea, but it's meant to be part of the armamentarium.
And you had mentioned something about that it's typically a GI that will prescribe PERT versus an oncologist. Is that?
Yeah, anyone can prescribe it, but gastroenterologists are more aware of it and utilize it more because they're seeing more patients with chronic pancreatitis who don't have cancer. And chronic pancreatitis, the incidence is very high across the world in the United States.
Mm-hmm, mm-hmm. But then it makes sense that once somebody has moved on to chemo or to a regimen such as that, that they're not seeing their GI again. Is that correct?
Yeah,
Generally.
the gastroenterologist role is more at the diagnostic and staging level,
Yeah.
and especially the interventional, and then it transfers more, as we all know, to the surgeon, the medical oncologist, the radiation oncologist. It's really important to keep the nutritionist engaged, even if the gastroenterologist not. The nutritionist can be immensely helpful in mapping out a diet, ensuring sufficient caloric intake, sufficient weight maintenance or weight gain, and
So
is
that's
a
yeah.
component of that.
Go ahead. I'm sorry.
Yeah, no, go ahead.
So that's important for us to hear because that's an area of awareness that we certainly can do some help with that. I'm going to ask you one more question, and then we're going to move on to questions and answers from the audience. First of all, I'll let you know what Ethna said to this question about what is the area of research you're most excited about for changing patient outcomes. And she indicated that for promise of early detection, and typically the funding in pancreatic cancer had been focused on treatment, and so there have been many advances in treatment as we've heard today. But in the last few years, with the increasing interest in trying to find the diseases earlier, it seems logical that treating end-stage disease is so much more challenging than treating an early-stage disease. So she felt that the challenge will be to really push early detection forward. And from your point of view, what are you most excited about in changing patient outcomes?
I agree with what she says, and you and I discussed as well. Early detection is really key. That's going to have substantial meaning in terms of outcomes. How to implement, with what to implement, and how to implement are two hurdles that remain. But I do believe, I'm optimistic that we can overcome that. I think also, and that more and more emphasis on obtaining the family history, because then one, that person may have a gene mutation. Two, even if they don't have a gene mutation, but they have a robust family history of pancreatic cancer, as well as associated other cancers, then we could put them into surveillance programs. So I think and the surveillance programs are one pathway to early detection.
Mm-hmm.
So I think for me, family history, that's key and obtainable by anybody and everybody.
Mm-hmm. Thank you. That's another important point for us on the coalition to take to heart. So I'm going to ask you some questions, Anil. And the first one, though, I'm going to answer. Could we get a summary of this discussion? Yes, you will get a summary of this discussion. And Jenny Isaacson behind here has been taking notes on everything, which is great. So that there will be a link that'll be sent out on that. The other question on this is the prevention of younger diagnosis, the future of early detection. In other words, being able to diagnose people at a younger age, this younger cohort that we talked about today, is that included in the future of early detection?
I would say yes. The hurdle there being who do we apply that to? So we can't do that in the broad population. So we have to come up with biomarkers, as we've discussed, whatever that represents, whatever they represent, and we have to have some cues, some clues, then applying those biomarkers for early detection in young individuals. In the case of colon cancer, with early onset colon cancer defined as less than age 40, right now, non-evidence-based, evidence-based screening colonoscopy should start at age 50, average risk, earlier if there's higher risk. A few years ago, that was moved up to age 45, but that's not evidence-based. that was driven by the publicity around early onset. So there's a tool there that's available. We don't have that same tool in early onset pancreatic cancer.
Okay, thank you for that. This one has to do with diet. Is there any data on diet comparing organic to non-organic foods more related to meat that show a difference in cancer generation?
Well, to the extent that organic foods might have less red meat, less fat, I would think that would be the relationship that I would think about.
Okay.
To the extent that organic foods are not processed the same way and don't have theoretically preservatives, that might be another link.
Okay. What are your thoughts on laboratory developed early detection blood tests? I think this one is probably looking at pan blood tests. Is this a good option to offer as an alternative to patients?
In the right setting, type 3 diabetes or family history, I think that the pancreatic cancer, we really have to continue to focus on those who are at somewhat higher risk than average risk.
Mm-hmm.
And then whatever tools are possible in a logical way, in a rational way to apply, do it in that setting. But I don't think we should be applying these tools sort of ubiquitously.
Mm-hmm. So it's thoughtfully to be applied at
Yeah.
this point. Yeah.
Because of the lack of absolute sensitivity and specificity in at least what we have, it can also boomerang. So let's say there's a borderline abnormality. Well, what to do with that information? Patients, well, imaging is negative. No symptoms, no signs, and so do you keep repeating the tests? Do you keep imaging? And if you keep imaging, how often to image? The level of anxiety that will go up is just enormous. We face this in genetic testing when we don't find a true mutation, but we find what's called a VUS, variant of unclear significance. Spend a lot of time reassuring the patient it's not a true mutation. Well, it's very difficult for the patient to understand that.
Yeah. Okay. Thank you. What is a recommendation for people with a cured, in quotes, primary cancer experience who have been diagnosed with pancreatic cystic lesions, but without any symptoms?
Pancreatic cystic lesions?
Yeah. Mm-hmm.
Yeah.
But without any symptoms. What are the
So,
GLS?
so if I understand the question correctly, let me step back also to put it in the right background. About the age of 60, the prevalence of pancreatic cysts is 1 to 2% of the population. It's huge.
Yeah,
It's
that's large.
millions, right? That's that's 3 to 6 million right there. And so often they're discovered serendipitously on imaging for something else. Kidney stone, get a CAT scan, gallstone,
Mm-hmm.
typically an ultrasound, but sometimes a CAT scan. Patient has diverticulitis, they get a CAT scan, so you pick up a cyst. Okay, because typically it's acquired in a lifespan, and typically it's not necessarily hereditary. Occasionally, you can find germline gene mutations in patients with cysts. So there are multiple types of cysts. Most of them are totally benign. The ones that we worry about that are pre-malignant, that can evolve over a longer period of time than pancreatic ductal adenocarcinoma. So the histology for the pathologist under the microscope looks different, and the rate of growth is different. One is called mucinous cystic neoplasm, or MCN, which is typically found much more in women than men, typically women in their 40s, 50s, and 60s. And it typically occurs in the tail of the pancreas. So we monitor that, and if there's certain abnormal features based upon texture and size, then that patient is destined to go to surgery. It's not the Whipple surgery, but the tail of the pancreas is removed, and the outcomes are great.
Yeah.
The other one is called IPMN, intraductal, within the duct, papillary because it looks like frond-like projections. Mucinous neoplasm, mucinous because it's secreting this gelatinous material. And IPMN can either occur in the main duct, think of it as the main highway, or a side branch, think of it as an exit from the highway. And depending upon size, texture, and whether there's a solid nodule within the cyst, then those are features individually or collectively that will not only dictate surveillance, but eventual surgery. So we have rigorous debate between the professional societies, not in the nomenclature of these cysts, but the frequency of surveillance, because most of these cysts are stable, small, benign, and never change. And some societies argue that we over-survey. Some say we can't afford to under-survey. So it's really important to be working in a center that has a lot of experience with pancreatic cysts, between surgeons, interventional endoscopists, gastroenterologists, and radiologists, those three.
Yeah, and there's obviously an emotional factor here for the patients too, to think if they have an
Exactly.
uncertainty,
It's
and
not
what does
so
that
much the
mean?
cyst
Yeah,
that
the
makes
stress
me worry.
involved with
It's the
that.
cyst in the pancreas, because cysts you can find throughout the body from head to toe. You can find them in the brain, the lung, the liver, very common there, kidney, very common there. But it's the fact that it's in the pancreas that understandable that it causes worry and anxiety.
Yeah, thank you on that. Do you know of any evidence that the addition of neoadjuvant stereotactic radiotherapy helps to shrink tumors enough to get patients to surgery?
Yeah, I would say decades ago, neoadjuvant radiation therapy alone was an approach at some institutions, not all. I would say at this point in time, neoadjuvant radiation therapy alone may not be or is not a favored approach. It might be so in combination with chemotherapy. In the adjuvant setting, in other tumors, it might be helpful with immunotherapy, other types of tumors. But a major clinical trial suggested in the neoadjuvant setting it was not helpful, combinatorial radiation therapy, chemotherapy, but that study had certain types of criteria and approaches that some have questioned.
Mm-hmm. Okay. Okay. Stephanie from Canada is bringing up an interesting study in Mexico about stones found in 98% of the patient's stool who were hospitalized due to pancreatitis. Since there's a connection to pancreatitis and pancreatic cancer, she wonders if the stones have ever been researched with pancreatic cancer. Kidney stones, I'm assuming.
Kidney
Gallstones?
stone,
I don't know.
gallstones.
Stones.
Um,
Stephanie,
oh, well,
the type of
in
the
chronic
stone.
pancreatitis, you can start to see, because of the inflammation and fibrosis, that can impinge on the main pancreatic duct. So narrow, it's dilated, narrowed, and large. So you sort of see saculations. And pancreatic ductal stones the pancreatic fluid can precipitate, and you can get pancreatic ductal stones that exacerbates the chronic pancreatitis. That's independent of gallstones, kidney stones, and so forth. Chronic pancreatitis in and of itself is the best known risk factor for sporadic pancreatic cancer. A classic study by Lowenfels in the New England Journal in the 1990s, followed patients out 10 years and 20 years. I'm not sure or aware of any relationship if you have chronic pancreatitis plus stones, if that augments the risk for pancreatic cancer. I think view the pancreatic stones as a manifestation in some patients of chronic pancreatitis, but I suspect, because it's sort of mechanical in nature, I suspect it doesn't augment the risk that you see in chronic pancreatitis. By the way, you can see KRAS mutations, RAS mutations in chronic pancreatitis, and sometimes it just stays chronic pancreatitis, and sometimes it goes to pancreatic cancer. So there are strategies to try to detect RAS mutations in chronic pancreatitis, because maybe those patients need to be monitored more closely.
Yeah, so surveillance might be different with somebody with chronic pancreatitis as a high risk group. But do you have any idea what percentage of of those with pancreatitis go on to develop pancreatic cancer?
Yeah, that study that I was alluding to, after 10 years, it's a twofold increase, and after 20 years, a fourfold increase. So,
So it's less than new onset of diabetes, which is
Yeah.
6 to 8 times. Yeah.
Yeah.
And it's more like what common diabetes is, which is probably twofold.
and that risk in chronic pancreatitis is what causes the chronic pancreatitis. Largely, it's alcohol induced, and it's sort of a direct relationship with the amount of alcohol consumption. But at the same time, not all alcohol intake leads to chronic pancreatitis, and not all chronic pancreatitis leads to pancreatic cancer. Chronic pancreatitis, in 0 to 20%, one can see mutations in the cystic fibrosis gene. And so we often detect it, but we're not sure what to do with that information. They may not have cystic fibrosis. They may also have mutations in something called SPINK1, and that may be sort of a facilitator of pancreatitis, but it's not clear if that's pathogenic for pancreatic cancer. So it's a study that it's an area that's studied quite a bit, Barbara, by investigators in the American Pancreas Association.
Yeah. No, thank you. There are several other questions, but what we'll do is get the answers to these later, because we're just running out of time here. And I want to ask Anil the final one here, which has to do with the importance of advocacy groups and understanding the role we play in motivating, empowering, and supporting change and research on behalf of patients and families. So what is your final message in 30 seconds or less about the role that members of the World Pancreatic Cancer Coalition play in changing outcomes globally for pancreatic cancer?
It's huge. It's enormous, no doubt. It's necessary. It's motivational. It's energizing for patients, families, communities, but also scientists, physicians, nurses. It's absolutely necessary. And some of the most dramatic legislative changes in the United States and the world are a reflection of advocacy. And all of you are to be commended for it. And it's inspirational for the rest of us. There's absolutely no doubt. And we ourselves enjoy participating in advocacy efforts. It's very important. I like to go out to patient groups in particular and speak. It's really important, because I feel like I'm playing my little role in education and awareness then. But I also enjoy going to the U.S. Congress, working with local Congress people, congressmen, senators, so forth. So it's absolutely critical. There's no doubt.
And with Dr. Joe Biden as well. Thank you. Thank you again, Anil. And Ethna, if you're listening, again, we thank you for all the comments that you had sent me ahead of time, and for both of you sharing your knowledge and expertise today. It was really a very informative and thought-provoking session. So now it is my pleasure to turn this session back over to, is it Craig? I'm not sure.
15-minute break will be beginning right now, but we'll put everybody back into the ballroom.
Thank you.
Thank you both.
Thank you, Barbara. Thank you to Ethna as well.
Thank you. Take care.